Poštovane dame i gospodo, dobar dan i dobrodošli na okrugli stol u organizaciji Hrvatske komore fizioterapeuta s temom Fizikalna terapija na razini primarne zdravstvene zaštite. Čast mi je i zadovoljstvo što mogu u ime organizatora pozdraviti predstavnike svih komora u zdravstvu i sve vas danas ovdje okupljene. Cilj ovog okruglog stola je poticanje rasprave, ali i pridonijeti rješavanju negativnih učinaka zanemarivanja uključivanja djelatnosti fizikalne terapije u primarnu zdravstvenu zaštitu. Oko 50% bolovanja čine problemi koštano-mišićnog sustava koji u prosjeku budu od 3 do 5 mjeseci na bolovanju i nisu u mogućnosti pristupiti fizikalnoj terapiji zbog lista čekanja na sekundarnoj razini. 2014. godine ukinuta je uputnica za fizikalnu terapiju, tako da je jako dug put pacijenta do fizioterapeuta. Kroz niz predavanja koja danas slijede dobit ćemo uvid u prakse drugih zemalja. Nadamo se i odgovoru na ono pitanje hoćemo li ostati jedina članica Europske unije koja nema organiziranu fizikalnu terapiju na razini primarne zdravstvene zaštite. Prije nego započnemo s predavanjima i prezentacijama, pozivam zamjenika ravnatelja Nastavnog zavoda za javno zdravstvo dr. Andrija Štampar, Brunu Cvetkovića, da nam se obrati i sve nas pozdravi. Izvolite.
Hvala. Evo, mislim, nemam ništa spremljeno, ravnatelj je nažalost zadržan, pa evo, ja ću pozdraviti skup. Drago mi je da ste odabrali našu ustanovu da kod nas održite ovaj skup. Drago nam je da smo domaćini. Naravno, kažu da je vježbanje pola zdravlja, a ako nismo zdravi i ako ne možemo normalno izvoditi vježbe, onda je tu fizikalna terapija da nam pomogne da izvodimo pravilne vježbe i da se vratimo u normalu, da možemo normalno funkcionirati. Svakako podržavamo inicijativu da se uvede na primarnoj razini zdravstvene zaštite i timovi za fizioterapiju i ako ćemo moći ikako to bolje podržati, mi ćemo to svakako kao Nastavni zavod za javno zdravstvo podržati. Htio bih vas sve pozdraviti u ime našeg ravnatelja, profesora doktora Branka Kolarića i u svoje ime, a obzirom da sam i dopredsjednik Hrvatske komore zdravstvenih radnika i u ime Hrvatske komore zdravstvenih radnika također pozdravljam ovaj skup. Želim vam uspješnu raspravu i da dođete do nekih zaključaka koji će biti sprovedeni i prihvaćeni od strane našeg ministarstva. Evo, to je to. Hvala.
Hvala puno vama na uvodnim riječima. Sada pozivam doktora znanosti Tine Kovačića, predsjednika Društva fizioterapeuta Slovenije, da nam se također obrati.
Dobar dan. Najprije iskrena hvala predsjednici Hrvatske komore fizioterapije Mirjane Grubišić na pozivu na okrugli stol. Kao dobri susjedi, a posebno kao odlični kolegi, fizioterapeuti želimo pomoći jedni drugima, a posebno i pružiti podršku u implementaciji dobre prakse te prikazati koristi od organizacije fizioterapije na primarnoj zdravstvenoj zaštiti. Najkvalitetnija istraživanja utemeljena na dokazima navode da takav model pomaže u smanjenju čimbenice rizika za kronične nezarazne bolesti, smanjuju isto komorbiditetu, smrtnost, rješavaju nejednakosti u zdravlju, povećanju kvalitete života i općenito smanjenju financijskog tereta liječenja akutnih i kroničnih bolesti. Sa mnom su i kolega Janez Špoljar, dopredsjednik Zbora fizioterapeuta Slovenije, te Petra Žagar, predsjednica sekcije fizioterapeuta u primarnoj zdravstvenoj zaštiti, koji će predstaviti slovenski model. Želim vam uspješni okrugli stol i naravno uspješna implementacija modela što je prije moguće u Hrvatskom.
Hvala vam puno. A sada pozivam glavnog tajnika Europe Region World Physiotherapy, Aitor Carpio García. Tema je Europe Region World Physiotherapy and our involvement at EU level. Mr. Garcia, the floor is yours.
Okay. First of all, thank you so much. Thank you to the Croatian Chamber of Physiotherapy for inviting us to be here today. Today I'm going to be speaking about ourselves, European World Physiotherapy, who we are, and afterwards Esther-Mary will introduce you to how is primary care in physiotherapy at European level right now. So first of all, who are we? We are the European region of World Physiotherapy. World Physiotherapy is a global organization for physiotherapy, which has 125 member organizations at global level and represents around 700,000 physiotherapists at global level. There are 5 regions, one of which is a Europe region. That's we, that's us. We were established in 1998. We have right now 36 member organizations at European level, not only in the EU, European level, and we represent around 200,000 physiotherapists in Europe. These ones are the individual members of our member organizations, which are national physiotherapy associations. Here you have our Twitter handle, in case you want to follow us on Twitter. That's where we post all our news. So this is how we are organized. There is a general meeting each 2 years that elects the executive committee, that elects the working groups and the secretariat. The working groups are our core, so they are the ones, I will speak about them a bit later. They are the ones which implement our actions. And then the staff, so the secretariat, which I'm the head of, we help them implement or deliver all the papers and deliverables that they agree on at the start of the term. This is our strategic plan for the next 4 years. This was approved in May 2022. So these are our 4 main objectives for the following 4 years, as I said. The first one, we obviously seek to demonstrate the value and impact of physiotherapy. We would like physiotherapists to be recognized by the national authorities as autonomous professionals in the national healthcare system. We promote excellence in physiotherapy education, practice and research. This is done through our working groups. I will speak about that a bit later. And we obviously strive for being more influential in relevant policy development at EU and national level. Our office we are based in Brussels, so we are in close contact with the different EU institutions, such as the Commission or the European Parliament. As I was mentioning, we have 6 working groups running right now, currently, 3 permanent working groups, the advocacy and EU matters, the education matters, and the professional practice, and then 3 thematic working groups for musculoskeletal disorders, cancer, and mental health. This one is new. It was recently created in May after the general meeting. So I would like to offer you an overview of what these working groups are doing and what they will be doing. I will start with the advocacy and EU Matters working group. As I said, and linked to our strategy objective, they conduct a biannual survey on professional autonomy in Europe. So we need to assess every 2 years how is professional autonomy in Europe at European level. They organized recently, last year, a webinar on direct access to physiotherapy in primary care, which I think, and Esther-Mary will speak about that a bit later, but I think it's a really good piece of information. The recording of this webinar is on our YouTube page, so it can be accessed by anyone at any time. We also surveyed our member organizations regarding the role of physiotherapy in long COVID. Of course, this is a recent problem. We are still studying how to manage it, but of course, physiotherapy has a key role to play in this. Then we are really involved in the EU Health Policy Platform, which is an instrument of the EU in order to be in contact with the European Commission and other health stakeholders at EU level. So in this kind of forum, we unite with other health professions in order to go with or to get common messages for the Commission to implement the different initiatives on health. These are the different EU developments and initiatives that we are, just some of them, that we are involved in, such as following or the next work plans for the next years, Europe's Beating Cancer Plan, which I'm sure you will have heard of, different EU consultations on different topics, and things like the health technology assessment and many others. This is the work that will be done in the next 2 years. We will follow with the report. We will do a report on the survey that, as I said, was sent during the last term to the member organizations. So we will have a report on that. We will also have a second webinar on direct access to physiotherapy in primary care. So I think this is, for the topic that we are discussing right now, this will be a very interesting webinar. We are also working on a position paper on the value of physiotherapy in the prevention of non-communicable diseases. And as I said earlier, we are in close collaboration with different EU organizations to promote the profession. Not only EU institutions, but as I said, other health stakeholders, such as a standing committee of doctors, such as nurses at European level, and many more. With regards to our Education Matters Working Group, during the last term, there was we organized a congress on physiotherapy education. It was planned to be in person, but finally we had to switch it to an online format. We produced a statement on physiotherapy education in the European region. So what's the minimum standard that the physiotherapist should have at European level? We also developed a briefing paper on CPD. And also a guidance document on what are the minimum competencies that a physiotherapist should have at entry level. Again, we have a close relationship with many health organizations at European level, such as the European Public Health Association, the European Pain Foundation, or the European Network of Physiotherapists in higher education. As for the work to be done, we will be reviewing the documents that I just introduced you. So we will do a revision of those documents to see if it needs to be improved or amended in any way. We are going to do a document on promotion, because we would like to promote research among physiotherapists and among the physiotherapy community, because in Europe there are some countries where there is a lot of research done by physiotherapists, but there are other countries where physiotherapists do not perform that research. Why? Why is that? We wanted to analyze the causes in order to tackle the issue. After that, we will do a webinar on that regard, so on that topic, and then we will be working, or the Education Matters Working Group will be working on a document on clinical education in physiotherapy. With regards to the Professional Practice Working Group, there were several webinars that were arranged during the past term. One related to long COVID, which I was mentioning earlier. So how to get patients from ICU to for them to recover. We also did one on COPD, and in all our webinars we try to promote always the use of clinical guidelines. During the past term, we also did a position paper on how big data influences physiotherapy, and what's the role of physiotherapy with sustainable development. Also, I wanted to comment here, ESCO, which is the European Skills, Competences, Qualifications and Occupations. And truth is that we were really involved with this. We were actually key for defining what physiotherapy is in Europe. Here you have a small text on what ESCO, this is like a database of professions that tries to define what are its professions. And this is the definition that came up from the round of consultations, not only among physiotherapists, among expert physiotherapists, but also with other health professionals, such as I was mentioning earlier, such as the nurses or the doctors. And this was actually agreed by the European Union. Again, mentioning our involvement with EU developments, of course, the EU Beating Cancer Plan that I think I already mentioned earlier. We are really involved with the European Forum for Primary Care. Actually, one of the members of our executive committee is in the advisory board of the European Forum for Primary Care. So, I mean, the relation between physiotherapy and primary care is, in Europe, is, I mean, there is no question to that at European level. Then we also have relations with the European Public Health Alliance. There is European Public Health Alliance and European Public Health Association. We have relations with both of them. And then, as I was mentioning earlier, for us, guidelines are very important, and we also have a very big involvement within, which is a platform for guidelines at international level. As for the work to be done, we will be identifying actions from the paper on big data. We will be following up on the issue of long COVID, and we will be reviewing the different documents that we have produced during the past terms, again, to see if any amendment should be done. What I commented are our permanent working groups. Now I will be mentioning very briefly our thematic working groups. As I said, we have 3 thematic working groups: musculoskeletal disorders working group, cancer working group, and mental health working group, which has been recently created. With regards to the MSD's working group, our main aim was to be involved in the EU OSA, which is the European Agency for Safety and Health at Work. So we were really involved with their campaign on the prevention of work-related musculoskeletal disorders. There were many infographics produced by us, and then obviously this is all evidence-based. There were many infographics produced by us and other communication materials that we delivered mainly through our social media, but also through webinars. For instance, we did a webinar in collaboration with EU OSA last year. So again, the link between prevention of musculoskeletal disorders at work and physiotherapy, the link is crystal clear, and there is no doubt about it at EU level. We started producing a booklet with practical examples of workers who cannot go to work due to neck and back pain, which we are finishing during this term. And then, as for the work to be done, as I said, we will continue with this booklet, and we will be involved in the new campaign of EU OSA, which is going to tackle telework. So what are the diseases, mainly the diseases related with, or the main risks related with telework. So we will be working in that campaign with EU OSA as official campaign partners in the next 2 years. This is an example of a couple of infographics. The one on the left is the one that we produced. The one on the right is one that was actually lent to us very kindly by one of our working group members. So these are kind of the things that we do in order to make it very visual. With regards to the cancer working group, we produce a position paper on the role of physiotherapy in the pathway of cancer patients. And after that, we produce an infographic. Again, we always try to make it as visual as possible. So we produce an infographic with the main statements from there. From this position paper, we also did a webinar. And I wanted to comment that we are really involved with the EU Commission. The EU Commission is giving a lot of priority to cancer and to mental health, and in this regard they have created a contact group so stakeholders can provide their views. We are within that contact group, so we are in close collaboration with the EU Commission in this regard. As for the mental health working group, as I mentioned, this is a new group, so we are still studying the actions to be taken by us in this regard, but truth is that the EU Commission, as I just said, is giving a lot of priority to this issue, to this topic, and actually a mental health strategy will be issued by the European Commission next year, so we are in touch with the different health stakeholders and the EU Commission to see the content of that strategy. And again, our role is to highlight the importance of physical activity in this regard and the importance of physiotherapy in this very hot topic. And then, just really briefly, I wanted to comment on, right now we have 2 EU-funded projects running in the European World Physiotherapy, one that has to do with promoting physical activity among elderly people, and another one which has to do with prevention of cancer, again, through physical activity. And we are the coordinators of this project, and yes, I think this helps us to kind of promote the role of physiotherapy that physiotherapy has to play at EU level, and I think these are key for us and for the profession. And that's all. I mean, thank you so much for listening. Thank you so much.
Upalit će se. Thank you very much, Mr. Garcia. Sada pozivam Esther-Mary D'Arcy, predsjednicu Europe Region World Physiotherapy, da nam se obrati i održi predavanje. Tema je Physiotherapy in Primary Care and Cost Effectiveness of Physiotherapy. The floor is yours.
Good afternoon, everyone.
No, it's fine, I think.
Just music. Yeah, okay.
Thank you. Thank you, Leona, and thank you, Aitor. It's absolutely lovely to be here in this beautiful city, in this beautiful weather. Thank you to Mariana and to the Croatian Council of Physiotherapists. I'm delighted to come and speak to you today. Before I start my talk, I would like to say that I was very surprised that primary care is not part of physiotherapy. For us in many countries, it's an integral part of physiotherapy. So we hope that by being here today, that we can help to support the integration of primary care into physiotherapy in Croatia. I'm also delighted to find that you're in the final phase of recognizing physiotherapy as a scientific discipline within the clinical science and medicine field. This is very important for the profession, and if we can give you any help in bringing that to the final phase, we'd be delighted to do so. I've always been interested when I go to conferences that people show up slides of beautiful places where they live, and I thought, well, actually, I live in a beautiful place as well. So I come from Ireland. I live on the very far part of the west coast. My next parish is America. So I live in a small village with 20 houses, and I cycle down and swim here every day. At the moment, the water is 10 degrees, and it goes down to about 5. And on very warm days, it goes up to 18. So it's much warmer to swim in Croatia. I need to turn this on. So, with regard to primary care in the European region, we have been partners in the European Forum for Primary Care for many, many years. We've had a member of our, either our executive or one of our working groups sitting on the advisory group for maybe 12 years at this stage. And currently, one of our executive committee members is standing for the board of the European Forum on Primary Care. So I think that gives you some idea of where we stand with regard to primary care. As part of that forum, we have presented on autonomy and self-referral, also on the role of the physiotherapist in primary care, and indeed an article, evidence-based article, was produced and published in the European Forum Primary Care Journal. The link for it is here. And we in the region developed several years ago a statement on physiotherapy in primary care in Europe, and that is available on our website. I think in terms of physiotherapy, like all areas of health, and I'm so delighted that representatives are here from the nursing chamber and from the medical chamber. Healthcare is evolving, and that's the way it should be. And we, as healthcare professions, need to evolve with it. We're increasingly involved in primary care because of these changing needs. In Ireland, for instance, the whole primary care plan is to treat 95% of the population with 95% of their conditions as close to their home as possible. So the whole move is away from hospital-based work with the emphasis on primary care. We all have an aging population. We all have people, more people with chronic conditions living longer. And also that there are advances in treatment that allow the physiotherapist to work in primary care and outside the hospital situation. This is a somewhat old slide at this stage, but I just wanted to show you that this is the memorandum of understanding that we have between the European medical doctors and ourselves, in which both of us respect the autonomy of the other. This is our statement on primary care. I'm not going to go into and read the whole statement, but I just wanted to draw your attention. Sometimes we think about primary care as being about physiotherapy and primary care as being about musculoskeletal conditions, but of course it's much more than that. And in primary care, we're involved in treating patients with neurological conditions, cardiorespiratory conditions, pediatrics, women's health, and of course the whole area of occupational health as well. So this is a paper that I think, with regard to primary care, that's well worth those of you who are interested in looking at this paper. Aitor mentioned that we like to do infographics. We like to make it a bit more readable, and this is I suppose, a readable version of the paper. I wanted to show you this. This is the model that we use in Ireland, and it's used in other countries as well, in terms of the primary care team. So always, as with all our work, the patient is right in the centre. It used to be long ago that there was a triangle with the patient at the top and things. Now it's the patient is centre place, as the patient should be. The whole approach is a patient-centred care approach. And then we have core teams and then outer teams. And in that core team are 4 people: the general practitioner, the local medical doctor, the physiotherapist, the nurse, In this case, the nurse would be what we call the public health nurse, so and the social worker. So the country is divided into primary care teams, and every team has this core group of people in the team. And then we have primary care networks, which have the second layer, so they would have occupational therapists, speech and language therapists, psychologists, mental health nurse. And then moving further out, you have the social services, the home helps, various things. So as you can see, the needs of the patient are met in the primary care within the primary care team. I'm moving on to talk a little bit about clinical effectiveness in physiotherapy, but I'm going to concentrate on that clinical effectiveness in primary care. I have a few other examples, but I'm going to concentrate on primary care. Again, this is determined by things like health economics, increasing patient expectation. There's a lot of responsibility on all of us as healthcare professionals, because the public and the patients are rightly having high standards of what they expect from us. We have growing waiting lists. I'm sure that's the situation in Croatia as well. I think that's a European phenomena. And we also have increasing healthcare costs. So there is pressure on us to deliver services effectively, both clinically and economically. I'm going to show you a few examples from the United Kingdom. They have a very interesting series of examples called Physiotherapist Works. And in developing these papers to show the evidence, they actually involved a health economist, so that not only were you looking at the clinical impact, but you were also looking at the health economic impact of physiotherapy. And obviously, physiotherapeutic intervention as opposed to surgical intervention perhaps is much less costly. So I want to acknowledge the CSP in the UK for the use of these examples. And also, I'm not going to go into the clinical improvements. I want you to assume from the evidence that the clinical improvements are implied. Okay, I'm talking about the sort of the different impact of this work. So what we're looking at are cost savings in primary care. So by treating people in the community, there's less admissions to hospital. The readmission rates go down, so people with chronic conditions, such as chronic respiratory conditions, are admitted less to hospital because they're being treated and managed in the community. If they do have to go into hospital, that the length of stay in hospital is less. We have certainly found that with physiotherapy in the community and in primary care, the prescription rates, the prescribing rates, the medication has gone down, and therefore the cost. Okay, and also it has a great impact on health staff absenteeism rates as well. So, just one or two examples of hospital as opposed to primary care. But a physiotherapy early-led mobility protocol showed a decrease in the ICU and hospital length of stay, reducing it from 14.5 days to 11.2 days, and saving 7% on standard patient care costs. Pulmonary rehab, which is a very big part of our work in the community. This led to a reduction again in the length of stay following pulmonary lobectomy, with intensive respiratory physiotherapy in the community, reduced the mean hospital stay from 8.3 to 5.7 days. And the reduction in readmission through pulmonary rehabilitation in patients with COPD exacerbations showed a 26% reduction in the readmission rate. In stroke, we now have a situation where the patient spends very little time in hospital. They are discharged as early as possible to have an intensive rehabilitation program in primary care. So very often patients are, once they're stabilized, are discharged possibly within 24 hours, and they're immediately put in contact with the rehabilitation primary care team. Okay? These are specialist stroke services. So the physiotherapist, the occupational therapist, the speech and language therapist would all have specialized in the treatment of patients with stroke. It really is helpful in terms of reducing long-term dependency and admission to institutional care and length of hospital stay. So it's really a no-brainer. In dementia, it was an inpatient service that was then followed up with a home service, and it showed, once again, reduction in the length of hospital stays and future health admissions. And 58% of those people were able to return home. I don't know about here in Croatia, but very often prior to this, people with dementia were admitted to hospital and very often didn't go home. They may have gone into institutional care or residential care, but didn't get home. So this is very helpful. Children with cystic fibrosis, we're treating them more and more in the community. And by doing that, we've discovered substantial healthcare savings by significantly reducing the need for intravenous antibiotic treatment and hospital admissions. And obviously this makes a huge difference to the people with cystic fibrosis, particularly to the young children. Falls prevention program, very big part of physiotherapy in primary care. We have reduced admissions with a physiotherapy-led falls prevention program in the community. And this was done over a 10-year period in Glasgow in Scotland. And what that program showed was a reduction in admission due to falls in the home by 32%, in institutional care by 27%, and in the street by nearly 40%. So we have a huge preventative role in primary care. In multiple sclerosis, we had a physiotherapy-led multidisciplinary team service for people with multiple sclerosis. And the results of that were decreased visits to the general practitioner, decreased visits to the hospital consultants, and then the hospital bed days in 38 people over a 6-month period, thereby reducing really inappropriate use of inpatient beds. In lymphedema, and this was an area that I worked in myself, a cost comparison study showed that the cost of managing early-stage breast cancer-related lymphedema was 80% less per patient when using a prospective physiotherapy surveillance model compared with reacting to symptomatic presentation. So again, huge emphasis on the prevention. Just giving you some figures about self-referral in primary care, and you can see some of these are even quite old, but there was a pilot done with 6 areas in the National Health Service in England between 2006 and 2008, and the number of associated costs for investigation and prescribing, 75% did not require prescription medicines. Okay? And because of a pilot like this, then the whole approach was rolled out nationally. Okay? Work absence was down, and the average cost to the NHS in Scotland of self-referral in 2009 was estimated at 2.5 million per annum. And the Scottish Health Minister said that they actually could not do without self-referral in primary care in physiotherapy. Their health service wouldn't stand up if they didn't have it. And one other example, just 100 million, over 100 million GP appointments were saved by making the physiotherapist the first contact practitioner for patients with back pain and other MSK disorders. And this freed up the general practitioners to deal with other more complex issues that patients have, and very much supported by the GPs, and allowed them to do other work. So it's a win-win situation for everyone. There was some talk earlier about staff absenteeism, and I just wanted to show you this in terms of reduced health service absenteeism by having a walk-in facility for staff for physiotherapy rehabilitation. And this allowed over 50% of people with injuries to stay at work. And those who were out of work, about 1/5 of them were able to return within 8 days, and the remainder within 30 days. So 2 government departments in Northern Ireland, at the top of the island where I live, offered this service to staff, and 80% indicated that physiotherapy had prevented their absence at work. Aitor has shown you this, and I just want to show it to you again. And I suppose it's about the importance of physiotherapists in occupational health, because you've got to ensure that the programs that are being taught are evidence-based. You know, it used to be a lot of sit up straight, elbows at 90 degrees, make sure you're not slouching and things. And this work, which actually, this posture on the right, which was actually led by a colleague of mine in Ireland, the research has changed dramatically. And of course, we must make sure that we're promoting that. It's no longer sit up straight 90 degrees and your chair has got to be right. In fact, what they've discovered is that you can be comfortable. It doesn't matter what the position is, but you've got to move. Okay, and you need to move frequently. So all offices should allow their staff to get up and move around frequently. Okay, I know that in the Dutch Association, in the morning when they go in first thing, they start with an exercise program. Okay, I'm standing here to talk to you. I do all my computer work in standing, so that I then can leave it and move around and do a few exercises on the floor, a few planks. You've got to get people moving, right? So you've got to make sure as well that your people in primary care are looking after occupational health and posture are physiotherapists, because they are the people with the expertise. This was just an initiative about saving working days, and these were 2 in London. John Lewis is a big department store in London, and they had physiotherapists in working, and they saved from that kind of work. They saved 41,000 working days, saving €2 million in 1 year, simply by having physiotherapists come in. I'm very proud of the fact that in Ireland, in fact in Europe, the first physiotherapists in occupational health worked in Ireland. And guess where they worked? They worked for Guinness. I hope there was no drinking on the job. I'm sure there wasn't. But in the 1940s, they employed physiotherapists to work in-house. And it was smart. The people didn't have to go out, they weren't losing time, and also the physiotherapists could look at the work areas and advise people as well. So it was a smart move, like many smart moves by Guinness. I'm just going to leave that one. Okay, so I just very quickly want to move on and talk about an initiative, a primary care initiative that we had in Ireland. Are you still with me? Yes, okay. Sorry, I should just acknowledge that this was in conjunction with the Royal College of Physicians in Ireland, the National Health Service, what we call the Health Service Executive, and our rheumatology and our orthopaedic clinical programmes, and ourselves as the Irish Society of Chartered Physiotherapists. So this was a joint initiative, and in fact the rheumatologists and the orthopaedic surgeons came to us about this initiative, and it was to address their waiting lists, because they felt that physiotherapists could see the patients on their waiting lists. Okay? I'm just going to talk a little bit about the background, the education involved, and the outcomes. Okay, again, similar to what I said earlier, you know, media pressure, waiting lists getting longer and longer instead of shorter. Obviously, the European Working Time Directive, which meant that doctors couldn't work beyond 48 hours in a week. They had been working 56 and 72 and things. So it was the safety aspect was concerned. So who was going to do that work and take up the work that they couldn't do? So the yellow on your left, I should never have done physiotherapy, I can't tell my right from my left, shows you what it used to be like. The patient went to their general practitioner, the general practitioner referred them to a specialist, they went on a waiting list, the acute condition was becoming more chronic. The more chronic it becomes, the more difficult it is to treat. The specialist saw them and referred them to physiotherapy. They went on a waiting list for physiotherapy, the condition becomes more chronic, more difficult to treat, and eventually they see a physiotherapist and they need a lot of physiotherapy. So the orthopods and the rheumatologists said, this is ridiculous, okay? So we changed the whole thing around, and the patients will first come to see the physiotherapists. Okay, and then if the physiotherapist thinks that they need to see either a rheumatologist or an orthopaedic surgeon, they refer them. Okay, and that's what it was all about. So the whole thing was obviously to provide timely access to physiotherapy, to improve the access for the patients who required further investigation or specialist opinion, and to improve the communication and streamline the services. So what we did was we created 24 advanced practice physiotherapy posts. They were in hospital, but they were primary care posts. Okay, in order for a physiotherapist to apply for this post, they had to have 5 years postgraduate qualification, and they had to have worked for at least 3 years in MSK. So they were specialists in MSK. And then they were trained to triage. So just very quickly, 12-day course, 11-day course, and 1 day of assessment of competence, theory and practice. The course was provided by physiotherapists, orthopaedic surgeons, rheumatologists, managers, psychologists. Supervised practice was looked at, and then the supervising consultant did a triage assessment, and then the physiotherapist had to do 2 presentations. So this was the kind of thing that they covered. Okay, obviously pathology, pharmacology, caseload management, flags, red flags, yellow flags, health economics, and the legal aspects. And I know time is running out, so just to give you an idea of the kind of what was involved in the course. Obviously, they had to look then at differential diagnosis and the whole clinical reasoning, which is just part of the backbone of physiotherapy. And then they screened the patients, and obviously they had to look at other things. What was causing the pain? Was there vascular inflammatory joint disease, any neurological conditions, any endocrine disorders, and any pain interventions? And in a period of 6 years, those 24 advanced practice physiotherapists seeing patients in the community removed 140,000 people from the waiting list. I'm combining the orthopedic and the rheumatology waiting lists just for the basis. The interesting thing about this was that when the physiotherapists saw the patients, only 8% of the patients needed to see a rheumatologist, and only 11% needed to see an orthopedic surgeon. So that was an awful lot less than were sitting on those waiting lists for several years waiting to be seen. There were sort of recommendations because it was so successful. Then we've created a lot more advanced practice physiotherapists who are seeing these patients in the community. And we've moved it out into neurology and pediatrics. And they're now seeing, each physiotherapist is seeing about 1,000 new patients per year, triaging them and then referring them to physiotherapy if they need it or elsewhere. There have been several publications on the work, just to acknowledge that. And I also would like to acknowledge the CSP in the United Kingdom for permission to use their work, and my colleagues in Ireland for assisting with the information. And lastly, I could just sidestep a little bit and just, while I'm here in Croatia, to take the opportunity to thank the physiotherapists in Croatia for all of the work that they did during this incredibly difficult and challenging pandemic that we're still in. But I really, bow to their professionalism, their flexibility, the resilience, the collegiality, and the generosity of the physiotherapists, indeed across Europe. And we had many physiotherapists, as there were nurses and doctors, who developed COVID and indeed long COVID, and who've really had some physical and mental health issues as a result. And I think compassion fatigue has set in among all of the health professionals. So I just would like to acknowledge that and to thank you once again for inviting me to talk. Thank you.
Mrs. D'Arcy, thank you very much. Sada ćemo čuti iskustva prvih susjeda. Ostvarivanje prava na zdravstvene usluge u zdravstvenoj djelatnosti fizioterapije na primarnoj zdravstvenoj razini u Sloveniji je iduća tema. Obratit će nam se Petra Žagar, predsjednica sekcije fizioterapeuta u primarnoj zdravstvenoj zaštiti Slovenije. Izvolite.
Hvala. Pozdrav i sa moje strane. Ja sam Petra Žagar. Ja ću vam predstaviti ostvarivanje prava na zdravstvene usluge u medicinska djelatnosti fizioterapije na primarnoj razini kod nas u Sloveniji. Kod nas osigurana osoba može doći na fizioterapiju na osnovi radnog naloga i ovaj radni nalog utvrđuje osobni oziroma obiteljski liječnik. Može i napisati radni nalog i uputni liječnik. To su kao traumatologi, reumatologi, ortopedi, ginekologi i onda osigurana osoba ima slobodan izbor pružitelja fizioterapije koji su uključeni u mrežu javno-zdravstvene službe. U godini 2019 kod nas u Sloveniji 150.263 osiguranika trebalo je fizioterapeutske usluge. I u godini, ovo je narobe letnica, u 2020 godine 30.000 osiguranika koji su trebali fizioterapeutsku uslugu bilo je manje zbog epidemije COVID-a. Na dan 1. siječnja 2021. kod nas u Sloveniji 145 pružitelja je fizioterapije u 567 ambulantnih fizioterapeutskih timova. Znači da u 154 pružitelja fizioterapije radi 576 fizioterapeuta. I također u domovi zdravlja imamo i timove, također imamo 64 zdravstveno edukacijskih centara koji promoviraju zdravlje i skrbe za krepitev zdravja, gdje inače rade 80 fizioterapeuta. Evo ovako izgleda radni nalog za fizioterapiju kod nas. Ima puno informacija koje nam označiva liječnik koji napiše radni nalog. Ovdje ima informacija o izvođaču, o liječniku, može biti obiteljski liječnik ili uputni liječnik. Onda su informacije o osiguranoj osobi, preporuki, ako je izdavatelj radnog naloga liječnik koji upućuje, onda nam treba i broj uputnice i broj liječnika opće prakse. Onda liječnik nam označiva vrstu fizioterapeutskog tretmana, razlog obrade, zašto je osigurana osoba došla kod nas, zbog bolesti, ozljeđa, profesionalne bolesti, ozljeđa na radu i tako dalje. I za nas vrlo pomembna informacija je stupanj hitnosti. Imamo 3 vrste stupnje hitnosti. Prva je vrlo brzo. Ovo pripada stanju nakon svježih ozljeđa i operativnih zahvata. Priporočeno razdoblje čekanja je 14 dana. Onda je stupanj hitnosti brzo. Ovo pripada akutnom bolnom stanju i ponovnom akutnom kroničnom bolnom stanju. Priporočeno razdoblje čekanja je 90 dana. I stupanj hitnosti redovito. Ovo pripada kroničnim bolova, degenerativnim stanjima i priporočeno razdoblje čekanja je 180 dana. Prilikom stavljanja na listu čekanja uzima se u obzir stupanj hitnosti evidentiran na radnom nalogu. Odnosno stupanj hitnosti utvrđuje se tijekom njegove trijaže koju može kod nas obaviti i fizioterapeut. Ako je razina hitnosti naznačena na radnom nalogu, razina hitnosti utvrđena tijekom trijaže drugačija, primjenjuje se razina hitnosti utvrđena tijekom trijaže i moramo obvijestiti liječnika i pacijenta. Također lijekar označiva vrstu fizioterapeutskog tretmana. Kod nas imamo 4 vrste fizioterapeutskog tretmana. Najprvija je mali fizioterapeutski tretman. Ovo pripada lagano oštećenje funkcije i strukture lokomotornog sustava ili ograničenja lokomotornih aktivnosti. Fizioterapeutski tretman sadrži osnovne fizioterapeutske postupce. Fizioterapeutova procjena je pregled i procjena stanja, mjerenje pokretljivosti mišićnog kapaciteta, boli, funkcionalnih testova i drugo u inicijalnom tretmanu i za završni nalaz. Mali fizioterapeutski tretman traje 30 minuta. Prosječan broj obiska na liječenju je 6 puta i kod nas imamo utege s kojima se s kojima se vrijedi tretman i ovaj vrijedi 1 uteg. Stručna sprema koju možemo raditi, ovo su samo fizioterapeuti sa diplomom i položenim stručnim ispitom. Onda imamo srednji fizioterapeutski tretman, ovo pripada defektu i funkcije u građi lokomotornog sustava ili ograničenja umjerenih motorničkih aktivnosti. Sadržaj fizioterapeutskih tretmana je ista je procjena fizioterapije, ova traje 45 minuta i prosječan broj posjeta je 8 puta i vrijedi 2 utega. Onda veliki postupak, veliko je fizioterapeutski tretma, ovo pripada teža oštećenja funkcija i strukture lokomotornog sustava ili ograničenja motoričkih aktivnosti i promicaja koordinacije pokreta i ravnoteže zbog oštećenja neuromuskularnog sustava ili lakših oštećenja središnjeg živčanog sustava. Sadržaj fizioterapeutskih tretmana je isto osnovni fizioterapeutski postupki koji su obavljeni u šifrantu, u našem šifrantu. Procjena fizioterapije isto. Vremenska norma je 60 minuta, prosječan broj posjeta je 8 puta i vrijedi 2,67 utega. Onda imamo još poseban fizioterapeutski tretma, o tom mislim da će Janez poslije, kasnije malo više kazati. Onda donji dio radnog naloga, imamo informaciju o kontaktu liječnika, gdje ćemo šaljemo izvještaj o fizioterapiji, onda imamo i informaciju o inozemnih osigurancima. Onda nam liječnik u nas unosi i šifrant, unosi šifru dijagnoze prema MKB-u. Može i napisati kratki opis bolesti ili uzrok zašto osoba dolazi kod nas na fizioterapiju. Ako je razlogov za upućivanje na fizioterapiju više, upisuje se šifra glavne dijagnoze. Onda liječnik napiše i cilje fizioterapeutskog tretmana, cilji za koje želi da ih postičemo upućivanjem na fizioterapeutski tretman. Evo, ovo je zadnja stranica radnog naloga. Sadržaj fizioterapeutskog tretmana koje će liječnik može definirati sadržaj, može, ali nije nujno, sadržaj fizioterapeutskih tretmana i unijeti postupke sukladno s kratkom opisom ili dugom opisom zahvata i šifranta zavoda. Ali kod nas u Sloveniji ove postupke propisane su samo od specijalista fizijatra. Svi ostali liječniki i specijalisti kao ortopedi, traumatologi, niko nam ne definira šta moramo mi raditi, a to moramo birati mi sami. Onda kad osigurana osoba dobije radni nalog za fizioterapiju, može se kod nas naručiti poštom ili osobno. Dostaviti mora radni nalog izvođaču prema stupnjem hitnosti. Ako je stupanj hitnosti vrlo brzo, mora nam dostaviti radni nalog u 7 dana. Za stupnjem nujnosti vrlo hitro je i redovito, mora dostaviti u 21 dana. Ako ne, prestajemo radni nalog važiti. Onda se idu na listu čekanja prema stupnju hitnosti. Ako su na zadnjoj stranici propisani postupci na radnom nalogu, fizioterapeut ih je dužan pridržavati. Ako ih hoće zamijenjati, može, ali samo u dogovoru sa liječnikom. Inače, ako je definirana samo vrsta fizioterapeutskog tretmana, može fizioterapeut samostalno mijenjati sukladno sa rezultatima tretmana. Izvještaj fizioterapije. Kod svakog pacijenata imamo najprije fizioterapeutski pregled i napišemo početno procjenu stanja na osnovi pregledane dokumentacije, anamneze, inspekcije, palpacije, mjerenja i testova I na koncu obravnave ima i konačna fizioterapeutska ocjena i sve ovo ispunimo u fizioterapeutski nalaz i ga onda šaljemo doktoru koji nam je napisao radni nalog. Vremenska valjanost radnog naloga je za razdoblje jednog fizioterapeutskog tretmana. Ako hoće ponovno stići na fizioterapiju, liječnik moramo izdati ponovni radni nalog. Radni nalog, valjatnost radnog naloga je 1 godinu i počinje teći sa prvom fizioterapijom. Usluge radnog naloga naplaćuje nam zavod. Ako se fizioterapeutski tretman privremeno prekida, može zavod naplatiti nam cjelokupnu uslugu ako je obavljena najmanje polovina posjeta. Kako smo kazali, mali fizioterapeutski tretman, prosječna je 6 obiskov. Ako mi napravimo 3, onda može nam usluge naplaćati zavod, inače ne. I u Sloveniji imamo i plan izvođača i realizaciju u tekućoj godini. Jedan fizioterapeut u Sloveniji mora da napravi 289 predmeta, to vam je 289 pacijenata i uteži i ovih 590 uteži i mi moramo da dosežemo plan oboje i predmeta i težine. Ako ne obavimo oboje, onda nam zavod isplaćuje procenat manje koje nismo dosegli. I na končnom obračunu za kalendarsku godinu uzima se u obzir i osnovnih zahvata, 1/3 mora biti kinezioterapije u odnosu na prateće zahvate elektroterapije. To vam je na kratko kako mi to radimo u Sloveniji. Sa 1.1.2023. godine kod nas počnemo sa novim modelom naplate gdje ćemo imati plaćanu svaku posjetu posebej. I isto se nam obećava uvođenje radnog naloga za fizioterapiju. Hvala na pažnji.
Hvala puno vama. A sada slijedi tema fizioterapijska djelatnost u Sloveniji s organizacijske razine. Pripremili su je Petra Dovč, predsjednica proširenog stručnog kolegija za fizioterapiju pri Ministarstvu zdravstva Slovenije, i Bojan Čeru, član stručnog kolegija za fizioterapiju pri Ministarstvu zdravstva Slovenije. Zbog izvanrednih obveza nisu mogli biti ovdje, pa će sve prezentirati Janez Špoljar, magistar fizioterapije, dopredsjednik Društva fizioterapeuta Slovenije. Izvolite.
I'm sorry, I'm not that good in Croatian than my colleagues, so my presentation will be in Slovenian because my colleagues Petra and Bojan did it in Slovenian language, and I will speak in English as you can hear me. So I'm not a member of this extended committee for physiotherapy with the Ministry of Health, but I work closely with the second colleague that is stated here, Bojan Čeru, so I know quite a bit about the organization of this committee. So there are around 40 extended professional committees in Slovenia that work under the patronage of the Ministry of Health, from different medicinal so like physiotherapy, occupational therapy, rentgenology, and so on, and physiotherapy is just one of them. And of course, doctors have their own extended professional committees for internal medicine, for traumatology. So if the ministry has any professional issue, the ministry asks one of these committees for help. So it is like an advisory body of the Ministry for Health, and it was established in 2011 for the first time, and now from 2017 the mandate for this committee is 6 years. Of course, we work closely in our association for physiotherapy, Slovenian Association for Physiotherapy. We work closely with this committee for physiotherapy, and in this website that is in this website that is stated down, you can see, of course, in Slovenian, but the Google Translate always works. You can see all the stuff that this committee does for the ministry. We will leave this presentation, so you will have it always at your database if you need it, and again you can translate it quite easily. So up until 2014, it was a little bit different than after 2014. From this year on, the system is like Petra stated. So up until 2014, every doctor prescribed physiotherapy procedures, goals, the number of visits. The physiotherapist, unfortunately, mostly did not do it was not mandatory to do physical therapy assessment, and the database was mostly on paper. It was not like in digital form, and like the procedures were stated in the as you see, very old, like we said, green book, but it's like a Slovenian thing. So it was not all the PT procedures were there, so it was not 100% appropriate. There was no physiotherapy assessment at the end of the treatment, no mandatory report after treatment, and mostly it was the praxis that even within one visit, the patient went from one physiotherapist to another therapist, which of course we all know is not quality physiotherapy. Then from 2014, from 1st of January, the system changed. There was, prior to that, of course, there was a working group from Ministry of Health, the Committee for Physiotherapy within the Ministry of Health, the National Health Insurance, and from our association. So we came up with this new system that Petra said. So. Mostly, which is very important from our part, in more than 90% of the prescriptions, there is no physiotherapy procedures on the prescription. So it's only the small, medium, or large or specialist physiotherapy treatment, which is very important for us, because we can, and the doctors see it, the general practitioners see it, that they, as we heard today also, they don't have enough time, and they mostly just state the treatment and not the procedures. So we also did the new list of physiotherapy treatments, which is stated here in this website, which you can also see. It's in the PDF format, of course, again in Slovenian, but it's easy to translate it. And again, another important change was that the report of the physiotherapy was mandatory for physiotherapists to get paid for the treatment from the National Health Insurance Company. So there were quite some major changes in improving quality of physiotherapy, which are stated here. So of course, within this physical therapy report, it has to have the assessment of prior to physiotherapy, assessment after physiotherapy, the recommendations for further treatment, which is optional, all the procedures that we do and why we did it, all the parameters, what we saw during treatment are also optional. They are not mandatory. And of course, we encourage the use of standardized outcome measure. So in 10 years' time, most physiotherapists, physiotherapists went on the different approach, which was really mandatory, that one physiotherapist has the same patient all the treatment, so that the patient does not change physiotherapist, regardless what the therapy is chosen by that therapist or, of course, the doctor. So again, we can always measure and see what this physiotherapist did for the patient, because prior to that, one day one physiotherapist had the patient, the next day the second physiotherapist, and so on. So it was not really quality physiotherapy. And of course, everything is archived in the central register of the patient's data, which can be seen or has to be sent to the doctor and can be seen by the patient. So a little bit of our specialist physical therapy treatment. If the doctor has a patient that he thinks needs more than just, like Petra said, small 6 treatments or middle large treatments, 8 treatments, the patient needs a little bit more, there is a possibility for the doctor to prescribe 10 physiotherapists per 60 minutes per therapy. And this extended professional body, which I'm talking about, is the one that has the competence which gives the competence to the physiotherapist to really do this specialist treatment. So I don't know if this will work, but I can try. Again, you saw the website, so you can always check it with these websites, of course. So these are the criteria for doing the specialist physiotherapy treatment. So, for instance, if the doctor chooses the neurophysiotherapy of adults, if we go down here, the physiotherapists needs to have one of this combination of postgraduate courses. So he needs to have Bobat course for adults and advanced Bobat course, or he needs to have all the 3 proprioceptive neuromuscular facilitation courses. And then these are the combination. He needs to have Bobat and proprioceptive neuromuscular facilitation 1 or 2, or he needs to have PNF 1 to 3 plus Bobat Basic, or Bobat Basic for adults, or plus Syriax 1 to 3. So he needs to gather this postgraduate courses in order to do this physiotherapy specialist treatment. This committee has actually the competence to say which physiotherapists have all this, because they need to send the certificates to this committee, which then decides whether this is okay or not. And this committee also accepts all these courses to be really from the international instructors and so on. So and you can see it here in these websites. So there is a list of these physiotherapists that are on this, that are allowed to do the specialist physiotherapy treatment, that the professional committee gives them the possibility to be on the list if, again, they have done all these courses. So right now we have 270 physiotherapists that all together can do this different specialist treatment, musculoskeletal, neuro for adults, neuro for children, and so on. So this list of physiotherapists so this committee 3 times per year decides which physiotherapists are appropriate for this, and the physiotherapists send all the certificates to this committee, which goes through the papers and decides whether he is appropriate or not. So we actually do this for the National Health Insurance Company, and this National Health Insurance Company has this list. Of course, there are a few problems. Petra stated them again in this system. The one of quite major problem is that we are not paid if we don't do enough visits. So minimum of 3 or minimum of 4 visits has to be done for physiotherapists to get paid from the National Insurance Company. So if the patient, from whatever reason, stops with physiotherapy and did not manage to end at least 3 or 4 visits, then these visits are not paid, which is, of course, not normal. So this is one of the things that we will change with this new system from 1st of January next year, because every visit will be paid regardless of how many times the patient came to the physiotherapist. So of course, this will increase our autonomous practice, because we will be able to decide how many visits does the patient need. So right now, as you saw, the number of visits were prescribed by the small, middle, large or specialist treatment, and now the physiotherapist will have the autonomy to decide whether patient needs 3, 5, 10 or 20 treatments, which we have a little bit of fear amongst our therapists because of this, because as I may be like, we are still a little bit on the Balkans, so our patients are not really aware of that they are responsible in a way for their health. So some of our patients would like to see 10 treatments at the beginning of the prescription. They don't see why only 5 visits or only 6 visits are necessary. So this will be now from our side to really to explain to the patient why 6 visits is enough, why 3 visits is enough, and so on. And of course, long waiting lists, as we heard a couple of times today, are also a problem. Regardless, we have a different system, we still have too long waiting periods, because National Insurance Company pays as much physiotherapist as it does, and we are not able to influence the visits. of course, because we don't have direct access. We have direct access, like probably in Croatia, you have with when patients pay by themselves, but otherwise not. So, because we cannot, of course, reject the patient if we see that he actually does not need physical physiotherapy, or if we see that maybe he needs some other treatment, or there is a chronic patient or so on. So still, regardless of the quite good system, we don't have the possibility to influence the long waiting periods. So maybe the e-prescription, which will be implemented hopefully next year, will shorten a little bit these long waiting periods, because as we hope, so far, the patient can be in the system in different therapies, optionally with 2 physiotherapists. At the same time, now with the e-prescription, of course, he will not be able to enter more than 1 treatment at a time. So, of course, if we, with this e-prescription, with this new e-prescription, we work closely together with our association. Petra is also in this group. Our president of the extended professional body, which I'm talking about, is also in this group, and we very much want to have only physical therapy treatment on this e-prescription, so that we will have like not direct access, but at least all the other stuff that we could choose by ourselves. We are not sure if this will be the case, but we are sure hoping for, and we will insist on. So that's all from my side. Thank you.
Hvala vama. Čuli smo kakva je situacija u primarnoj zdravstvenoj zaštiti kod naših prvih susjeda. Zato ćemo sada vidjeti kakva je situacija u Hrvatskoj. Pozivam predsjednicu Hrvatske komore fizioterapeuta Mirjanu Grubišić da nam se svima obrati uz predavanje hoćemo li ostati jedina članica Europske unije koja nema organiziranu fizikalnu terapiju na primarnoj zdravstvenoj zaštiti. Izvolite.
Hvala. Evo, ja bih iskoristila priliku da se prvo zahvalim zaista našim gostima, našoj predsjednici Europske regije svjetske fizioterapije Esther-Mary i našem tajniku Europske regije Svjetske organizacije za fizioterapiju što su izdvojili svoje vrijeme da nam se pridruže. Isto tako predstavnicima Slovenije, predsjedniku doktoru znanosti Tini Kovačiću, ja sam dobro rekla, njegovom zamjeniku Janezu Špoljar i kolegici Petri Žagar. Zaista hvala vam lijepa što ste u ovim iznimnim trenucima za nas nam došli tu da nam pokažete i da pokrenemo aktivnosti još veće. To ne znači da nismo do sada ništa radili, mi smo puno radili, ali kao što je Janez rekao, mi smo na Balkanu jednom nogom, a jednom nogom u Europskoj uniji. Pa uglavnom Balkan više prevagne, zaboravi se, još su relikti u razmišljanjima, približavanju inače nekakvih standarda u Europskoj uniji daleko od nas. Zato evo smo i upravo tu da pokušamo nešto prikazati. Ovo će biti na web stranici, na streamingu, cijeli okrugli stol, tako da gospoda koja su trebala biti ovdje, a nisu, da čuju nešto, sigurno će vidjeti i nadam se da ćemo im malo približiti to šta bi trebali napraviti kad su sa jednom nogom u Europskoj uniji, a jednom nogom na Balkanu i koja noga bi trebala više prevagnuti u njihovim odlukama da nešto promijenimo. Ja ću biti kratka, jako kratko, zorno smo vidjeli gdje su došle druge zemlje. Mi u Hrvatskoj imamo sve prekrasno na papiru. Imamo Zakon o fizioterapeutskoj djelatnosti gdje je definirana fantastično naša struka, regulirana, zaštićena. Imamo Zakon o zdravstvenoj zaštiti gdje smo isto fantastično regulirani i postavljeni da jesmo u primarnoj zdravstvenoj zaštiti. Ali zapravo imamo i pravilnik o normativima i standardima koji opisuju kakva treba biti ordinacija fizikalne terapije. Ovaj pravilnik uglavnom koriste privatne prakse, ne? Mislim, on nije primjenjiv u primarnoj zaštiti, u fizikalnoj terapiji, u javnom zdravstvu, jer ona još ne postoji. Znači, taj pravilnik se ne primjenjuje za javno zdravstvo, a trebao bi. Zakon o zdravstvenoj zaštiti, kao što sam rekla, propisuje djelatnost fizikalne terapije na primarnoj zdravstvenoj zaštiti i to člankom 30 i člankom 103 Zakona o zdravstvenoj zaštiti. Međutim, Zakon o obveznom zdravstvenom osiguranju koji propisuje tko može ugovoriti fizikalnu terapiju u javnom zdravstvu, tu fizikalna terapija nije propisana. To znači da temeljni Zakon o zdravstvenoj zaštiti je jedno mrtvo slovo na papiru za fizikalnu terapiju u Republici Hrvatskoj. Naravno, razlog je zato što mrežu fizikalne terapije u Republici Hrvatskoj donosi ministar zdravstva, a na temelju te mreže Hrvatski zavod za zdravstveno osiguranje ugovara broj pružatelja zdravstvenih usluga u Republici Hrvatskoj. Naravno, ministar zdravstva nije donio mrežu za fizikalnu terapiju. I čime je onemogućio fizioterapeutu da radi prema pravilima svoje profesije i pravima pacijenta. Znači, problem je osnovni da bi uopće pokrenula se fizikalna terapija u primarnoj zdravstvenoj zaštiti, da naši pacijenti imaju pravo pristupa toj razini zdravstvene zaštite, da nije donesena mreža, ne postoji uputnica za upućivanje na fizikalnu terapiju. Nećete vjerovati, za vrijeme Jugoslavije je postojala uputnica za fizikalnu terapiju sve do 2014. godine. I onda su se neki sjetili, promijenili su model D1, D2, D3 i tako uputnica i jednostavno je nestala, nema je. Znači, mi kao da ne postojimo u sustavu fizioterapeuti, kao da nismo zakonom propisana neovisna djelatnost, da zapravo pacijenti dolaze do nas preko jedne druge struke, druge profesije. Nije donesen akt o formiranju jedinice za fizikalnu terapiju s fizioterapeutom kao isključivo jedinim nositeljem te djelatnosti. Fizikalna terapija je zapravo zdravstvena usluga, proces kojim upravlja isključivo fizioterapeut. HZZO ističe da je svjestan da nepropisno ugovara djelatnost fizikalne terapije prilikom naše komunikacije pismene u sklopu mreže da on nepropisno ugovara djelatnost fizikalne terapije u sklopu mreže fizikalne medicine, ali HZZO se opravdava da drugačije nije moguće iz razloga jer Ministarstvo zdravstva, odnosno ministar zdravstva, nije donio mrežu za fizikalnu terapiju na primarnoj zdravstvenoj zaštiti. Bila je jedna situacija, ja ću je usput spomenuti sada, gdje smo ulaskom u eurozonu, Republika Hrvatska trebala ispuniti neke uvjete i tako je postavljen jedan akcijski plan gdje je Europska komisija na ne znam koji način vidjela i prepoznala da fizikalna terapija nije ugovorena kao djelatnost i postavila je uvjet za ulazak u eurozonu da Hrvatski zavod za zdravstveno osiguranje otvori natječaj za fizikalnu terapiju, a Hrvatska komora fizioterapeuta da uskladi pravilnik o oglašavanju fizikalne terapije. Naravno, mi smo to donijeli, ali ovaj natječaj za fizikalnu terapiju je eskiviran na način da je ugovorena fizikalna terapija u kući, koja svi znamo nije posebna djelatnost, ona je potreban dio fizikalne terapije u određenim situacijama u kućnim okruženjima, ali nikako se ne može govoriti da se to smatralo smjernice Europske komisije za ugovaranje fizikalne terapije, da se mislilo na fizikalnu terapiju u kući. Naravno, pošto nema mreže fizikalne terapije, ali je postojala mreža tog organizacijskog modela za fizikalnu terapiju u kući, HZZO je otvorio natječaj za fizikalnu terapiju u kući. I naravno, ministar je u obrazloženju rekao da se to podrazumijeva da su oni otvorili natječaj, što ne odgovara istini i nije napravljeno po tim smjernicama. Nismo htjeli tjerati mak na konac sa tim komunikacijama i objašnjenjima, ali nadamo se da će ovo pokrenuti situacije da se prepozna fizikalna terapija na primarnoj zdravstvenoj zaštiti. I sad se pitamo da li trenutnim tempom reforme upravljanja i organizacije zdravstvene zaštite mogu u skorom vremenu poboljšati dostupnost i jednakost ugovornih korisnika HZZO-a pristupu usluge fizikalne terapije na primarnoj razini, ili ćemo ostati jedina članica Europske unije koja nema uopće dostupnost mreže fizikalne terapije na primarnoj razini. Ja vjerujem da sada mi nećemo stati sa ovim, naravno. Do sad smo pokušali diplomatskim putem razgovarati sa ministrom, nikad nismo dobili odgovor. Mislim da će se morati promijeniti taj način komunikacije, da budemo uvaženi dionici, da nas se barem obrazloži, a ne ništa ne odgovori, i da kaže možemo ili ne možemo iz tog i tog razloga, ili možemo i napravit ćemo tako i tako, idemo sjesti sa obiteljskom medicinom i sa liječnicima fizikalne medicine, ako treba, uopće nije sporno, i da vidimo šta možemo to napraviti, da mi uskladimo barem tu prekograničnu skrb. Nama će sutra doći, oni razvijaju puste centre za zdravstveni turizam, a fizikalna terapija nije prepoznata u našoj zemlji, ne? Tako da jednostavno i to je jedan od velikih razloga da ćemo mi, i nadam se da će se promijeniti način komunikacije nas kao glavnih dionika, prva razina dionika fizikalne terapije sa Ministarstvom zdravstva. Evo, hvala vam na pažnji i hvala vam što ste došli.
Hvala predsjednici Hrvatske komore fizioterapeuta. Prije nego otvorimo mogućnost postavljanja pitanja za današnje sudionike i raspravu, vrijeme je da čujemo riječ pacijenata. Pozivam Jasnu Karačić, predsjednicu Hrvatske udruge za promicanje prava pacijenata, da nam se obrati.
Dobar dan svima. Evo, vidjeli smo iz prethodnog predavanja koliko je teško biti pacijent danas u današnjem vremenu, kada imamo bezbroj mogućnosti, puno toga na raspolaganju, modernu medicinu, modernu dijagnostiku, modernu terapiju, a na kraju vidimo da ništa od toga nije dostupno pacijentu na način na koji bi to trebalo. Hrvatska je zemlja koja je moderna, ima javno dostupno zdravstvo, ali istovremeno vidimo brojne razlike i nepravilnosti koje se dešavaju našim pacijentima. To jako dobro možemo vidjeti u fizioterapiji. Isto tako moram reći da i pacijenti sami nisu svjesni svojih prava još uvijek na dovoljnoj razini kao što je to u nekim drugim zemljama Europske unije. Možemo govoriti o čitljivosti pacijentu, na njemu razumljiv način i razumljivosti, što je health literacy. Vrlo jedna problematična situacija za današnje pacijente koji su upoznati sa svojim pravima onoliko koliko su im te informacije dostupne. Najčešće na internetu i najčešće pune grešaka. I tako možemo vidjeti da pacijenti, što se tiče fizioterapije, uopće niti ne znaju koje su djelatnosti fizioterapije, što im sam fizioterapeut može pomoći, i isto tako još uvijek ne znaju razliku između fizijatra i fizioterapeuta, što često i sami nekad i mediji dovode u pitanje djelatnosti koje su apsolutno odvojene, i naravno da pacijent može o svojim problemima komunicirati direktno sa fizioterapeutom. Ono što se dešava u Hrvatskoj sada i u jeku ove reforme, koja je više jedna lijepa priča, a iz toga ne vidimo niti jedan zaključak koji bi se odnosio direktno na pacijente, u odnosu na fizioterapiju vidimo da pacijent neće dobiti ništa, neće dobiti ono što mu treba, a to je da ima kvalitetnu u primarnoj zdravstvenoj zaštiti fizikalnu terapiju. Znamo da danas većina ljudi, pa gotovo evo možda i svi ovdje prisutni, uvijek će ponekad će doći u situaciju i uvijek će im prvo na pamet doći da ih bole leđa recimo i sad ne mogu doći na posao, nisu tada koji dan radno sposobni i naravno da im je potrebna što prije fizikalna terapija ako imaju nekakav takav problem. I onda nam se događa da moraju čekati ko zna koliko mjeseci uopće da dođu na listu, o kojima je isto bilo prethodno riječi iz Slovenije i za to vrijeme niti su radno sposobni, a niti mogu ostvariti svoju zdravstvenu zaštitu i to je jedan od velikih problema koji se dešavaju. I ako vidimo volju i vidimo da ima načina za rješavanje tog problema, zaista ne vidimo razloge zašto se to na razini reforme ne bi riješilo i zašto bi Hrvatska bila jedina onda zemlja članica koja nema dostupnu takvu zdravstvenu zaštitu. Također napominjem da svaka pacijent iz bilo koje države Europske unije može zatražiti pomoć u drugoj državi članici Europske unije i ono što je interesantno da pacijent iz Hrvatske na uputnicu može otići u Sloveniju, dobiti zdravstvenu zaštitu i dobiti refundaciju troška koliko to košta u Hrvatskoj. Ali je paradoksalna situacija ako govorimo o fizikalnoj terapiji u kući, onda je interesantno da kako možemo nazvati u kući fizikalnu terapiju ako pacijent sad ode iz Zagreba u Sloveniju, u Ljubljanu i zatraži tamo fizikalnu terapiju i zato dobije refundaciju troška, a govorimo nečemu što se radi u kući. Tako da to je jedna paradoksalna situacija koja muči naše pacijente i zaista treba samo ulagati napore i dalje ne odustati od ove ideje, jer to ne samo da je jedan korak kako smanjiti troškove, kako u zdravstvu, kako napraviti što aktivnije radno stanovništvo, jer znamo da većina ljudi, naravno koji su radno aktivni, recimo svi od nas tu, kad se dogodi nekakav problem, da želimo da se što prije riješi, da što prije budemo i dalje funkcionalni, da se možemo vratiti svojim redovnim aktivnostima. Tako da zaista podržavam sve ove napore i što god sa moje strane mogu napraviti da to podržimo, da proguramo, odnosno da ne odustanemo i da natjeramo. Sad smo već mislim na dobrom putu da se taj problem riješi i mislim da ne treba odustati dok se ne dobije ono što treba. I za promicanje struke, jačanje uloge fizioterapeuta i pružanje potpune zdravstvene zaštite pacijentu, pogotovo na primarnoj zdravstvenoj zaštiti koja je osnova kompletne zdravstvene zaštite i njege. Eto, toliko od mene. Hvala.
Hvala gospođi Karačić, hvala svim današnjim predavačima, a sada bi zamolila sve one koji su danas izlagali da sjednu ovdje za stol, da ponesu svoje slušalice sa simultanim prijevodom, jer vrijeme je za vas. Ukoliko bilo tko od vas ima pitanja, molim vas da dignete ruku, predstavite se i kažete komu to pitanje postavljate. Izvolite. Ukoliko nema pitanja iz publike, onda bih ja postavila zapravo pitanje gospođi Esther-Mary D'Arcy. Vi ste na početku svom predavanja rekli da ste iznenađeni. Nakon toga slijedilo je još mnogo predavanja. Koliko ste iznenađeni nakon što ste čuli sve ovo danas, uključujući praksu od naših susjeda iz Slovenije?
Thank you. Yes, I'm still very surprised. I suppose for me, and as you can see from my grey hair, I didn't qualify yesterday or today, but when I trained in physiotherapy, there was physiotherapy in primary care, so I never realized that there wasn't physiotherapy in primary care. So when the President Mariana raised this issue with us, we were obviously very concerned. And I remain concerned, and obviously in the Europe region we are very anxious to support and to ensure that the patients within Croatia have access to physiotherapists in primary care.
This question is also for you. Nadate li se da će netko čuti ono što se danas ovdje reklo, dakle od strane Hrvatske komore fizioterapeuta, ali isto tako iz susjedne Slovenije?
I hope so. I suppose it's unfortunate that people were invited today who didn't come. And it would have been beneficial again for the patients to hear from that the ministry were here and that they were interested and that they wanted to learn about the examples of primary care in other countries with a view to introducing it here. So I hope that they will listen to I understand that this is going to be also placed on the YouTube channel of the Croatian Chamber, and I hope that the Minister for Health and the people in the various ministries will look at this and will learn and will look at neighbouring country. I mean, I've talked about England and Ireland, but you know, Slovenia is on your doorstep, and they have a system that obviously works very well. If I could perhaps just add two differences that we have in our countries, that the primary care service is free for the patients. It's not insurance or health insurance based, and also the patients can access it themselves. I know it differs from country to country, but you know, we have to make a case for Croatia to have the service for the patients.
Hvala vam. Imam pitanje i za naše drage goste iz Slovenije. Čuli smo zapravo iz udruge pacijenata da hrvatski pacijent se može naručiti i doći u Sloveniju. Događa li se to stvarno u praksi?
I'm sorry, actually, I don't know because I don't work in primary care. I know the system, but I work in a tertiary rehabilitation institute. Petra works in a town in Celje, which has 50,000 citizens, and maybe you know the Croatian come? No. Okay.
Ali ste vi u svom predavanju naveli liste čekanja i e-uputnicu od 2023. godine. Dakle, to nam je ista boljka, liste čekanja.
Yeah, because liste čekanja, they are, in our case, we have waiting lists because there are not enough program paid by the health insurance companies. Now we have enough physiotherapists because we have enough schools for physiotherapy, but we cannot persuade the health insurance company to pay more programs. So there is an issue of money now, in our case.
Hvala. S nama je ovdje i predstavnica Hrvatske liječničke komore, zamjenica predsjednika Vikica Krolo, inače liječnica obiteljske medicine, pa ću zamoliti mikrofon jer iduće pitanje je zapravo za vas. Kako vi vidite suradnju fizioterapeuta i liječnika obiteljske medicine i što to u konačnici znači za pacijenta? Jer su mnoge studije pokazale primarne zdravstvene zaštite da liječnici i medicinske sestre cijene integraciju fizioterapeuta i da je fizikalna terapija najtraženija rehabilitacijska usluga.
Je li potrebno da se dižem? Nije? Mogu ovako? Može. Pa hvala svima što su ovdje došli i ja stvarno ovdje u ime Hrvatske liječničke komore, osobito nas liječnika iz primarne zdravstvene zaštite pozdravljam sve koji su došli i gospođa Grubišić, koja je predsjednica Hrvatske komore fizioterapeuta, zna da dok smo još radili ovaj zakon o zdravstvenoj zaštiti 18. godine i koji je stupio na snagu 1.1.19. godine, sam ih jako podržavala u tome zato što već dugo zapravo kao liječnik obiteljske medicine vidim da bi mi tako nešto u radu jako pomoglo. Kao prvo, stvarno, pacijenti su duže na bolovanju, teže dolaze do usluge fizikalne medicine zato što je ona kod nas na sekundarnoj razini. Kad kažete liste čekanja, mene evo recimo baš u ovome bi bilo i pitanje kolike su to liste čekanja u Sloveniji. Svi pričamo o listama čekanja, ali sigurno da postoji razlika dužine. Znači, kod nas, ja sam to isto rekla, ljudi su nam dugo na bolovanju jer upravo fizikalnu medicinu ne mogu doći na red po pola godine recimo. Jer dok dođe prvo mora doći do liječnika, fizijatra, pa to je 2-3 mjeseca. Pa onda iza toga još mora doći na red za fizikalnu terapiju. Stvarno smatram da bi nama u primarnoj zdravstvenoj zaštiti ovo itekako trebalo. I ja se isto čudim našoj državi. Zašto? Jer mi imamo zakon. I mi smo država koja donese krasan zakon. Zakon je znači već od 1.1.19. na snazi, znači to već 3 godine pune teče i da mi nismo u stanju zapravo napraviti mrežu fizikalne medicine, ove terapije, da, i da nismo u stanju recimo otvoriti te ordinacije kako je predviđeno i da zapravo smo stalno na nekom čekanju. A mi u obiteljskoj medicini bi to objeručke prihvatili i ne samo mi kao liječnici, nego naši pacijenti. Bili bi sigurno pokretljiviji, zdraviji, brže bi išli raditi. Dakle, uopće nema dileme. Dakle, od samog ravnatelja HZZ-a Vukelića u jednom neformalnom razgovoru smo čuli, on je inače ortoped, koji je sam rekao da kad on operira, na primjer, koljeno, ako odmah ne dobije pacijent fizikalnu terapiju iza toga, da propada njegov rad. Na kraju krajeva on znači operira i nakon mjesec, dva, mi to svi znate, mnoga mišića atrofiraju ako se ne radi i još najljepše ako se to ne radi kako treba. A ja vjerujem da fizioterapeuti itekako znaju kako bi rehabilitirali pacijenta i onda zapravo jedan ortopedski dobar posao zapravo propada jer nema dobru fizikalnu terapiju. Mislim da je to svima nama u interesu i liječnicima, svih struka i ortopedima i fizijatrima u konačnici, jer liste čekanja su velike jer nam je teško doći i do fizijatara. Oni ne rade samo za fizikalnu terapiju, nego oni imaju i druge poslove. Dakle, ovo bi svakako smanjilo liste čekanja u Hrvatskoj, kažem, ne znam kolike su u Sloveniji, ali mi smo svjesni da nigdje na svijetu te liste čekanja nisu jedan dan i da ne moraju ni biti, da postoji određeni dio vremena koliko se može čekati, ali da bi nam ovo itekako pomoglo.
Imamo repliku.
Ja bi se malo nadovezala, ne samo smanjile liste čekanja, nego troškova. Troškova u sustavu zdravstva, što mnogi zanemaruju, ne?
Da, svakako.
Da.
Pa sami smo rekli, sve što god napravimo da što prije osposobimo pacijenta, prvo će on imati manju invalidnost, brže će biti pokretljiv, na kraju krajeva to u interesu svih nas, pacijenata u budućih, a troškovima u zdravstvu ne treba ni govoriti. Mi smo pričali, vi ste u najavi rekli koliko smo na bolovanju, koliko je i tu trošak države, a ovo bi itekako smanjilo i taj trošak ljudi koji su na bolovanju i vratili bi se brže na posao, u svakom slučaju, A da ne kažem, dobro bi pacijenata koji nisu na bolovanju, a koji će trpiti manje bol, ili ovo što smo rekli sekundarno, znači ako je pacijent operiran iz bilo kojih razloga, da će biti prije rehabilitiran i da će i ta operacija zapravo izgledati ortopedska, neka uspješnija, zato što je imao dobru fizikalnu terapiju iza toga.
Ima li možda sada neko pitanje iz publike? Evo, imamo, odlično.
Hvala, ja vas se lijepo pozdravljam. Moje ime je Snježana Benko-Meštrović i bavim se kardiorespiratornom fizioterapijom. Nisam u primarnoj zdravstvenoj zaštiti. Međutim, jako mi je interesantno što je gospođa D'Arcy govorila i kolega iz Slovenije. U nekoliko navrata su se spomenule nekakve specijalizacije. Moje pitanje, a tu je i kolega Gazić, ako se ne varam, ili je, i u zadnje vrijeme se priča o specijalizacijama medicinskih sestara u hitnoj medicini, pa je moje pitanje da li bismo paralelno uz rješavanje ovog problema koje je danas ovdje aktualno, možda razmišljali o tim nekim specijalizacijama, jer nije isto da li će taj operirani vaš bolesnik doći kod mene koja se bavim plućima uglavnom ili kod nekog tko je u tom području zapravo izvrstan. Mislim, ja znam da je ovo sad level up, ali možda paralelno...
Pitanje za mene, pretpostavljam. Što se tiče specijalizacija, ove tehnike, specijalne tehnike, malo možda je nespretno prevedeno, ali smo mi vidjeli da se to radi o neformalnoj edukaciji, jel tako? To su bobat, to su te specijalizacije takozvane za njihove obrnave, jel tako? To je neformalna edukacija koju mi u Hrvatskoj isto imamo. Sve što je kod njih nabrojeno, to imamo i mi. Sirijaksa i Bobata, Majtlanda i tako dalje. Što se tiče ovih drugih specijalizacija, to sam vas i upoznala, to znate da smo pokrenuli u Splitu, na sveučilištu u Splitu i da ćete vi tu biti, nadam se, među prvima koji će moći sudjelovati u izradi specijalizacije kardiorespiratorne sa sveučilištem Split. To sam vas upoznala jer vi ste stvarno number one u ovom području kardiorespiratorne fizioterapije i mislim da to do nove godine da ćemo završiti taj program specijalizacije, ali bit ćete pozvani na to. Joj, ministar. Gledajte, kolegice, problem je, ste vidjeli u Sloveniji? U Sloveniji ministar zdravstva ima kolegije stručne. Između ostalog i imenuje ih ministar kolegij za fizioterapiju i on je savjetodavno tijelo ministra. Tko savjetuje našeg ministra za fizioterapiju? Srednji ešalon administracije koji nema pojma o fizioterapiji, koji ne zna, mislim, i ne mora znati, ne da ih ponižavam, nego oni jednostavno su administracija. Oni nemaju stručnjaka ko će savjetovati ministra. Zatim to tijelo njihovo od ministar što imenuje za fizioterapiju, oni predlažu ministru na način da predlažu savjetu za zdravlje. A gdje je naš savjet za zdravlje? On postoji, ali ja ne vidim da on je u nekoj funkciji. Hoću vam reći da smo jednom nogom u Europskoj uniji, drugom nogom na Balkanu. Ne može se organizacija i reforma u Ministarstvu zdravstva riješiti ako oni ozbiljno sa ozbiljno strukovnim organizacijama ne sjednu ili imenuju nekakva povjerenstva ko će im napraviti nekakav okvirni program i onda mogu reći prihvaćamo, ne prihvaćamo. Ali sad samo je komunikacija u jednom smjeru. Vi njima pišete, oni to stave u ladice. Niti zna što misli, niti šta će napraviti, ni kaj će napraviti. Mislim, ne možemo, ako mi dionici na ovoj razini, ali nije to da se događa s našom komorom, tako i sa liječničkom komorom i ostalim komorama. Uglavnom jednosmjerna komunikacija i onda se mora ovako komunicirati preko medija na kraju. Ja se nadam da će se to popraviti u doglednoj budućnosti u Ministarstvu zdravstva, da će to ministar prepoznati, da to nije dobar način komunikacije sa dionicima u zdravstvu i da ćemo početi nešto konkretno napraviti, a ne da samo on rješava požare u zdravstvu. Reforma je sada da se rješavaju požari u zdravstvu. Kad nešto plane, onda idemo to riješiti. Nema neke temeljne reforme, tog smo svi svjesni, jel tako, doktorice Krolo?
D'Arcy se javila za riječ, izvolite.
Thank you, and thank you for your question. I think that when you look at the whole aspect of primary care and physiotherapy, you are looking at specialties within primary care. So we would have, like yourself, specialists in cardiopulmonary rehabilitation in the community, and the evidence certainly in the UK shows that where the cardiopulmonary rehabilitation is led by a physiotherapist, that the outcomes are the best outcomes. So when I'm talking about primary care, I'm talking about all of those services being available in primary care. The examples of decreasing the number of days in hospital is because the patients are being treated in the primary healthcare system. So we have outreach programs for patients with long-term respiratory conditions, attending physiotherapy for rehabilitation, advising them how to manage their condition. So we're trying to make them as independent as possible so that they manage their condition. We support them. They contact us if they need something, if they feel perhaps their condition is deteriorating. We go and see them, we treat them, and we try to keep them out of hospital. So it's the same in all areas: women's health, pediatrics, pediatric pulmonary conditions, pediatric neurology. All of the specialist areas work within the primary care area. I hope that answers your question.
Hvala vam. S nama je i predsjednik Hrvatske komore medicinskih sestara Mario Gazić, pa ću moliti mikrofon ovdje u prvi red. Vi ste slušali sva ova danas predavanja. Kako vi vidite suradnju s fizioterapeutima na primarnoj zdravstvenoj zaštiti?
Evo, dobar dan svima, sve vas skupa pozdravljam. Nadovezat ću se na odgovor na pitanje od kolegice, ali neću oduzimati puno vremena. Meni je malo neugodno, mi smo malo u boljoj poziciji nego fizioterapeuti, jer mi imamo posebnu savjetnicu ministra za sestrinstvo, imamo povjerenstvo za sestrinstvo u Ministarstvu zdravstva. Trenutno smo u izradi 24 specijalizacije za medicinske sestre. U tom povjerenstvu krenut će specijalizacija iz hitne medicine, tako da put do tog je bio izuzetno težak, izuzetno mukotrpan i znam ono što slijedi vama u vašem putu. Ono što ja vidim kao, možemo reći, partnerskoj komori, jer stvarno imamo odlične odnose sa komorom fizioterapeuta, da su to neki toliko banalni problemi. Imate dva osnovna problema: uputnica i mreža fizikalne terapije. To su nekad, gošća je rekla, su izbacili taj sistem čekanja, 2 puta liste čekanja, dupliciramo liste čekanja, radimo nepotrebne troškove. Dva osnovna problema su vam, kao što, bar ja koliko vidim odavde, uputnica i mreža fizikalne terapije, i mislim da je 90% vaših problema s tim riješeno. Ono što treba naglašavati stalno je kolika je ušteda za naš zdravstveni sustav, da se samo te dvije stvari koje su, po meni, se mogu riješiti za 10 dana ako ima volje. Ne, jednom odlukom se uputnice vrate i za 10 dana se donese odluka mreže fizikalne terapije i problemi se rješavaju. Ja se nadam da ćete uspjeti, vjerujem kolegici Grubišić da je na njezinoj upornosti i stvarno do sad je uvijek pokušavala diplomatskim putem na lijep način isposlovati te promjene. Ja se nadam da će svi oni i naša državna i zdravstvena administracija vidjeti koliko je to benefit i za pacijenta, za sam zdravstveni sustav, samo te dvije sitne stvari po meni. Evo ga.
Hvala puno svima. Ja bih vas molila da jednim velikim pljeskom pozdravite sve sudionike današnjeg okruglog stola. Hvala svima na dolasku, na konstruktivnoj raspravi, primjerima dobre prakse u Europi i predavanjima koja smo danas čuli. Sve vas pozivam na domjenak i nastavak neformalnog druženja. Lijep pozdrav i doviđenja.
Could I just say one thing? I would just like to thank the translators for all the work they did. Thank you very much.